knowledge burst topic is family empowerment, exploring parent training options for autism support. And so grateful that Karen Bears, PhD, Clinical Director, Seattle Children's Autism Center, Associate Professor at University of Washington, is giving time to us today to share on this topic. So, Karen, I am going to share my screen and your slides, and we'll get started.
All right, thanks for having me today. This is fun to talk with my colleagues from state neighbors to the east of me. I like to say I've also started dabbling. I've been in Seattle for 8 years now, but I started dabbling and visiting Idaho. My dad is working on trying to permanently move to Sandpoint. So we've been making trips. He lives in Montana, in Great Falls, Montana right now, but wants to make Sandpoint his retirement home. So I've had a chance to visit, and it's beautiful, beautiful country. So really appreciate the invite and excited to be here today to talk about family empowerment and thinking about different types of parenting interventions and supports that we hopefully can and should be providing to our families of neurodiverse youth. So let's go ahead and dive in. I think I have my disclosures that come up first. So my disclosures for this is that I do receive royalties from Oxford University Press in relation to the publication of the Ruby Parent Training Program. I also receive speaker fees from ABAC, where I do provider trainings. And I have consultation fees for Attend Behavior, which is an app-based version of the Ruby program. And I'm one of the developers of the Ruby program, which is why I have these connections in terms of my disclosures. Okay, so today, because I was given a smidge more time, we're going to be trying to hit three main objectives. One is just to talk about the importance of parenting interventions as part of comprehensive treatment models for autistic and IDD youth. And then I'm going to talk about kind of the landscape of parenting interventions, that it's actually quite complex and multifaceted. And the reality is our families often would benefit from different types of parenting support. So I'll talk about what is out there and think about ways we can provide those types of supports for our families. And then I want to end by, I'll do a little bit of an intro to Ruby as a model of care in relation to parenting interventions. And then I'm going to end by talking about how can we take these kind of parent-mediated models and make them work for families. And that means thinking about being responsive to unique family needs, common barriers we see in treatment, and just the clinical considerations to really, again, help support our families and their children. So let's give this a go. So I always start my presentations off with I call it my good news, bad news slide. So the good news is I can say we are getting better at diagnosing autism. I think I heard some hands raised around STAT training. Is that right? As in the early screening. So there you go. That's a beautiful example of how we've got some really great tools out there. And we're getting better at being able to diagnose and diagnose earlier. We know we can reliably diagnose between 18 months and 2 years of age. I will acknowledge still the average age of diagnosis is 4 years of age, and hopefully we can keep getting closer to that even younger age, but we're getting there. And I have operated on both the diagnostic side and the treatment side. And what I can say as someone who does diagnostic evaluations is we meet the family, we meet the kiddo, we give a diagnosis, and then we go into our feedback. And one of the things that we impress in that feedback is that if your child receives an autism diagnosis, they need services yesterday, and the more the better. So there is this emphasis on the importance of timeliness and access to care. And so our families leave that diagnostic evaluation with that messaging of needing to get their child in services, and then they just try to go do that. And what I say is they end up hitting a wall or a pipeline access problem where their child has the diagnosis, they're trying to get services, and they can't actually access the very services that we are recommending in those diagnostic feedback sessions. And I think about ABA in particular as a fantastic evidence-based intervention that also happens to be time intensive. So we're not usually talking about 1 hour a week of ABA. We're talking about 15 plus hours a week of ABA, which makes it personnel intensive. It means that behavior tech, for example, with that kind of model of care, can really only support a couple of kids in a week, if we're talking about a higher intensity model. And we're not talking about short-term interventions either, right? So it's 15 hours a week for months to years. So we have this interesting dynamic of having a really fantastic intervention that, unfortunately, by the model of care, creates a differential in the number of providers that can provide the service, which means that limits the number of families that can actually access the care. And so we're struggling with this. How do we recommend treatments to families, and how do we actually get them into those services so they can start that intervention process? Next slide. So just to kind of compound the picture, I found this visual several months ago, and I think it does a really powerful job of kind of, it's actually very small, I realize. I'll walk through what it is. But just take the visual as it is, which is a child in the middle with his family around him, and all the bubbles or all the different service systems a family of an autistic kid may engage with at any one point in time. So you have your medical service networks. That's the pediatrician. Maybe the child has epilepsy or GI issues, so they're going to the gastroenterologist and the neurologist. You have the other therapies, which is the orange bucket, the speech therapist, the OT, the feeding, the PT. You've got families that are trying to navigate what are adaptive recreation services, what other support services can I engage with, figuring out state insurance. I mean, that's a whole doctorate just to kind of figure that out. And then school related services, becoming an advocate for their child, all the things that our families are having to navigate. And what it is important to highlight is these are typically fragmented service systems of care, right? So the neurologist is not, regularly talking to the special ed teacher, who's not regularly talking to the private OT, who's not regularly talking to the insurance panel that's making decisions about, covering care. Our families are the ones, and our parents are the ones that are having to navigate and become essentially expert care coordinators for their children to make this complex system of care work. And if we think it just from a numbers perspective, what our families are navigating, it's an average of 4 to 7 treatments at any one time. The more challenges, developmental needs, the more systems of care they're involved with. So this is kind of, kind of the adding to the bad news of our families are trying to get access to services, and they're having to figure out to and navigate. So not surprisingly, we are often talking about working with families that are carrying a lot, have a lot on their shoulders, and are typically very, very stressed and overwhelmed as they're trying to figure all this out. Next slide. So the thesis that my colleagues have been operating under for the last 20 years is that knowing that this is the landscape of care, there is a need to expand the availability of treatments for autistic and IDD or just neurodiverse individuals that are certainly first and foremost empirically supported, but also time limited and cost effective. And what I want to be really clear is I'm not talking about replacement services. I'm not saying instead of ABA, we need to be doing other things, but it is how can some shorter term, lower intensity interventions be an adjunct to a while you're waiting, in combination with support for our families. Next slide. So this is really where parent training has come in. And it's a little background about me. I actually started in the field over 20 years ago. So yes, I'm aging myself there. Outside of autism work, I was a PCIT, parent-child interaction therapy. My mentor was one of the developers of PCIT, was the developer of PCIT. So I've been doing kind of parenting interventions for youth with challenging behaviors for quite some time. And that's just one intervention that is part of a cluster of interventions that have been out there for decades. We have decades of research to support that parents absolutely can be trained and empowered to become the therapist for their child, essentially, that they can learn the skills and strategies from a provider that they can turn around and implement in a way that promotes behavioral change, that is fantastic in and of itself. But what is also nice about parenting models, and again, these are the ones that have been around forever, is we know that we can do this work in a really time limited approach, that with 1 to 3 hours a week, 10 to 20 sessions over time, that we can really support parents to this place of effectiveness and empowerment around supporting their child. And again, lots of data to support this. But interestingly, the idea of parent training being a facet of autism services, despite the rest of the literature being around for years, is really relatively new. Within the last, say, 15 years or so, there's been this kind of emergence of how can we take what we know works outside of autism and see if it can work inside, autism related services. Next slide. I'm probably telling you all what you already know, but I want to emphasize why supporting parents of autistic and IDD youth is so important. One is that we know that autistic and IDD youth have relatively high rates of challenging behaviors. And when I say challenging behaviors, I'm talking about things like meltdowns or shutdowns, physical aggression, verbal aggression, destructive behavior, self-injury, and then we can get real topical or focal in terms of like things like pica, elopement, incaprices, etc. That our families, our kiddos are engaging in these behaviors with regularity, and our parents are the ones that are figuring out how to navigate them. And there's some literature to support that the most stressful part of raising an autistic child is not core symptoms of autism per se, but these co-occurring challenging behaviors, how to navigate them. What we see in alignment with the presence of challenging behaviors is also the presence of adaptive skills deficits. And so what we're talking about here are not the things that kids are capable of doing in terms of self-care and daily living skills, but what they are actually doing day in and day out. So I'm talking about brushing teeth, taking a shower, getting dressed independently, making a snack, pick a kind of daily living skills type behavior. And what we know is a lot of our kids really struggle around their adaptive skills and independent engagement of adaptive skills. And what we have research to support is a linking between the presence of challenging behaviors and the presence of adaptive skills deficits. Meaning, and just very practically speaking, we have parents talking about how their child knows how to brush their teeth, but doesn't actually do it day in and day out. And when you learn more about the story, what they talk about is their attempts to try to get their kiddo to have that be part of their daily routine is met with meltdowns or aggression. And so parents understandably kind of back off and reduce expectations or demands because their experience is when I try to promote these skills of independence, we end up in meltdown territory. And so this combination of the presence of challenging behaviors or the presence of adaptive skills deficits leads us to be working with really highly stressed parents that tend to engage in accommodation, which means they just work around the behaviors or work around those adaptive skills needs. And the example that I give is a family I was working with. It was a kindergartner, average kind of cognitive skills, grade level. And the mom's routine was putting him on the couch, putting a TV tray in front of him, putting his breakfast in front of him and turning on the TV. And then she would proceed to feed him and dress him while he watched his morning cartoons. And, mom said, this is a kid that, could do it. There weren't like gross motor or fine motor skills delays that might have impacted, getting dressed, for example. But what the mom did say was, I got to get out of the door on time. My kid can't be late to school again, and I can't be late to work again. I'm going to lose my job if I force the issue to make my kid get dressed independently. So I'm doing what works for my family. And for me, that's a moment to reflect. Like, I hear you, and it makes a ton of sense. That that's how you essentially figure out how to navigate the daily routine. But the question is, where is the option to kind of work on that dynamic and create the ability for parents to feel more successful and more empowered in navigating these situations and in the process helping them to support their child to be more independent. And that's really where the parenting support interventions can come in. The last thing I want to point out is that parents want good they want good parent training. That's how I need to emphasize the word there. There's this kind of like idea out in the clinical world that parents don't want to engage in therapy. Like they want to drop their kiddo off and pick them up at the end, or they wonder why they're the focus of treatment. And there's been some interesting research kind of digging into this phenomenon. And what has been learned is that it's kind of a negative feedback loop where providers tend to engage in kind of like crisis of the day, backward facing what already happened. And we'll talk about the thing from last week, or just like spot case management that doesn't help the parent feel like I'm moving forward. Like what do I do the next time? Like how do I become more predictive and action oriented around support? And then so they don't want that. And so then that reinforces the provider saying, I try to do parent training with them and they don't want to engage. But what we've seen is when we actually, I call it when we give them the good stuff, they like it and they want to engage in that. So I think the emphasis on is how can we not just do parent training, but how can we do good parent training? Evidence-based parent training, interventions that we know can promote successful, positive behavioral change or skill acquisition. And the good news in our field is there is a ever-broadening range of options that we can lean into support our families and their kids. So next slide. So hopefully I've made the case that parent training is a good thing and that we can try and figure out ways to help support our families. But I do want to take a moment to talk about what exactly I mean by parent training. So I mentioned that I came from the PCIT world, and outside of autism and IDD, when you're kind of in general child mental health land, and you say you're doing parent training, providers are typically cued into some sort of like parenting intervention for challenging behavior. It could be PCIT, it could be Incredible Years, it could be Triple P, but there's usually clarity around like, what do we mean by parent training? That is not the same case in autism. And I kind of, was it about 10 years ago, I was at the Marcus Autism Center in Atlanta, Georgia. And we were kind of going around talking about what we're doing. And I was like, well, I do parent training. And the person next to me was like, well, I do parent training too. And then the person next to them was like, well, I do parent training too, except they're all doing very, very different things. And so it made me realize that there's a lot more going on when we're thinking about parenting interventions for autism. And it kind of compelled me, because this is how my mind works, to kind of actually like lay out like, what is the landscape of parent training interventions? So if you look at the next slide, this is actually a taxonomy that my colleagues and I developed, or kind of just, it's a roadmap or a taxonomy. We published this in 2015. I'll tell you, it's already out of date. And I'll tell you why in a minute. But if you see here, what we started with was kind of breaking things down by programs that are more about supporting parents, where the focus is kind of like enhancing knowledge around their child's needs, systems of care, and the child really is the indirect beneficiary of that service, versus parent-mediated interventions, where it's about directly teaching the parent the skill so they can turn around and directly use it with their child, and the child is the direct beneficiary. So that's how we kind of started breaking things out. The new arm that's been coming out as of late, so I'm very eager to actually revamp this particular article and add a third arm called parent-focused interventions. Because what we're hearing about now are things like mindfulness interventions or acceptance and commitment therapies, where the focus is on helping the parent. Like it's parent-focused work. So just know that there's this whole new arm that's even kind of come out as of late. But when we look at kind of this original model, within the indirect kind of parent support arms, that's where we have our care coordination, which is, I would say, if we go back to that diagram of all the bubbles, and my fantasy is that every parent has a care coordinator, that every parent has someone to facilitate navigating all those different systems of care and can support them. Because right now, that's the parent's job. The parent is the care coordinator. Psychoeducation is just any of the 101s. 101s on navigating the educational system, 101 on what is autism, 101 on how to support your transition age youth. There's all kinds of things where we're just giving knowledge to families to help support them. And these are oftentimes classes, or webinars, or sometimes meeting with a family support specialist that might be doing psychoeducation. On the parent-mediated side, we have interventions for parents that focus on core symptoms. So that could be things like language, play, other forms of communication. And then we separately have parent-mediated interventions for co-occurring behavior. So these are the things that are not required for a diagnosis of autism, but are oftentimes commonly co-occurring. So the big buckets are any kind of challenging behavior like meltdown, aggression, etc., but also sleep problems, toileting, feeding issues. We think about how many autistic and IDD kids have feeding challenges. So, those things that we commonly see with the kids that we're serving. And then just because our field cannot be simple, we broke it down even further by primary versus complementary parent-mediated intervention. So primary parent-mediated intervention is one where from the get-go, the parent is the one you're working with in treatment. They're every single session, they're the ones that are driving the intervention, et cetera. Complementary is where the work may start as therapist to child, but the parent is brought in to generalize the care support. So I had the Early Start Denver model on there. That was originally designed to be it's still designed to be a therapist to child intervention, but they had 2 times a month meeting with the parent to help the parent learn the skills. Just as a note, now there is a PESDM, which would be a primary PMI for core symptoms. So our ESDM colleagues figured out how to also just develop an offshoot that is really parent focused. The Ruby program, which is what I developed with my colleagues, is a primary PMI for co-occurring challenging behaviors. Maybe one takeaway from this is to know that there's lots of options for our families. There's lots of things they hopefully could have access to, but also to reflect the complexity of what is out there, and to when you're communicating with the parent about the need for parent interventions, I would challenge you to be specific. Is it for core symptoms? Is it for challenging behaviors? Is it psychoeducation? What type of parenting intervention are you saying this family needs to really help address whatever might be on their radar? In terms of research around these interventions, most of the parenting interventions for core symptoms that are coming out are affiliated with what are called naturalistic developmental behavioral interventions. So we're talking about programs like Connie Cachery's JASPER program, or the Early Start Denver model, or PRT, pivotal response treatment, or training. I never know what the T is, treatment or training. It's one of those. As Julie's saying, training. There we go. Those are interventions that, again, are more that kind of core symptom focus. And if you look at the publications, again, the last 10 years is when we're starting to see publications come out about those interventions. And I have some examples of parenting interventions on the challenging behavior side that I think we'll see in just a minute. So let's go ahead and look at the next slide. Here, next slide. So here are some examples of parenting interventions for autistic youth, specifically in that challenging behavior bucket. And what we have are kind of 2 branches on this tree. One branch is interventions that have been out there for a long time and have recently been modified or adapted in some way to support autistic and IDD youth. So PCIT is actually a great example. Parent-child interaction therapy was not developed for autistic youth, but in the last, 10 years or so, there's been this application, piloting, testing, efficacy for autistic youth. Incredible Years, again, has an offshoot. Triple P has an offshoot. So there's kind of those modified interventions, and then you have a handful that were developed from the get-go for autistic youth. So Ruby is a program that was from scratch made with autistic youth in mind. The AIM High program, which comes out of California, is one that was developed for kind of the mental health care system, the youth mental health care system in the state of California. And then Predictive Parenting is one that's coming out of the UK, which is a really cool one because it's melding kind of behavior analytic strategies for challenging behaviors and CBT strategies for anxiety, which is important because especially for the older kids I see, a really good chunk of them, the behaviors we're seeing are rooted in anxiety. It's something about my life feels unpredictable. I feel overwhelmed, and my behavior is my way of letting you know I'm feeling it. So this idea that an intervention for quote unquote challenging behaviors actually infuses considerations around anxiety is a really cool kind of uh, component for the kids that we support. So the last thing I'll say about the slide is, again, if you look at the reference dates, you know, we've got 2009, 2015, 2016, 2018. This is a very, very new kind of branch of intervention research that's coming out. But the good news is that it's looking really, really promising in terms of efficacy. Next slide. So for those that might be familiar with kind of some of the more common parenting interventions that are out there. So again, I'm thinking about incredible years, PCIT, et cetera. And then you look at these interventions that have been modified for autistic and IDD youth. I wanted to kind of point out what they all have in common, and then what is kind of unique about the parenting intervention specifically for autistic and IDD youth. So the kind of bread and butter strategies of parenting interventions is like, how can we improve the relationship between the parent and child? And this can just be by using kind of core principles of social reinforcement. So like catching the child being good. This also can be elevating it to more formalized kind of like child-led play or special time. In Ruby, we just talk about like, how can we get the two of you in the room together and figure out a way to enjoy each other's company, right? Like that's kind of like the foundation of those types of strategies. We can also do more targeted reinforcement contingencies like first this, then you earn this, or, you know, if you do this, this is the cool reward you get. That's kind of a bread and butter strategy for parenting interventions. And then you see things like planned ignoring or differential attention, like how can we maybe change how we respond when we might have like a negative attention seeking behavior. We have instructions around how to like have more clear instructions to facilitate the child being able to be successful when there's an expectation. And then interestingly, timeout is typically a bread and butter strategy for the kind of parenting interventions outside of autism. I'll use Ruby as an example. It's not a bread and butter strategy for us for a couple of reasons. It's a supplemental session. But I did want to acknowledge that if you're doing kind of one of those interventions that's been around for a really long time, you're likely to see timeout as one of the strategies that's being taught. So next slide, to talk more about like what we focus on in parenting interventions for challenging behaviors in particular, or actually really any intervention for an autistic or IDD kiddo, is this fundamental idea that behavior is communication, right? So when your child is hitting, they're trying to tell you something. When they're running out of the room, they're trying to tell you something. When they break that thing, they're trying to tell you something. And so the key to thinking about what to do about it is first thinking about why is it happening in the first place? What is that behavior trying to communicate? This is certainly particularly important for our autistic or IDD kiddos where their verbal communication is limited, where they can't easily tell you what they want or what they need, and that their behaviors are literally their way of communicating, functionally or maybe sometimes not functionally. But so because of that, because it's so important for us to understand what a child is trying to communicate, we rely on the antecedent behavior consequence model to figure out the function of the behavior. Again, what is the behavior trying to communicate? So that is a really important kind of strong emphasis in these types of interventions, thinking about using a behavior analytic approach to understand behavior, and then to turn around and think about intervention strategies. We also like to think very carefully about setting events. So this idea that there might be something that it could be perceptible to us as the caregivers, but it very well may not be, but it's kind of an undercurrent or an underlying percolation that kind of leads to maybe a challenging behavior. So I always use the example of the parent turns the TV on and the child starts screaming. And the parent might be thinking that they're just being ornery about the TV show that I turned on. But what we're talking about is a child who's already kind of in a state of kind of sensory overload from maybe other things in the day. Those would be those setting events. And then the TV gets turned on, which also has kind of an auditory kind of sensory experience. And that is just the piece that just kind of pushes the kiddo over the edge in terms of their kind of sensory experiences, and that's what's leading to the behavior. So we think way more broadly about what are contributors to why we might be seeing a behavior. We also think about you know, for our kids that may, have rigidities or kind of need things to be a certain way, or they do better when things are predictable. Sometimes behaviors are because they are in a can't state versus they won't state it. And what I mean by that is they're, for example, asked to do something and they literally cannot do it in that moment. There's something like the transition was unpredictable, or they were in the middle of something that really needed for them to be finished before they could transition. And so their behavior is a response to that versus what I call a won't behavior, which is I could totally do it. I know exactly what to do. I've done it a million times before, and I just don't feel like doing it right now. And one of the important things that we work on with our families is to help them broaden their lens to, why behaviors are happening in the first place. And that I think I have this in a later slide, but essentially this idea that not defiant non-compliance is probably the least likely explanation for why you're seeing a behavior. And if that's the case, then let's think about what our alternate explanations might be. And this work around thinking about ABCs and functions, about setting events, et cetera, is what can help support that work or facilitate those conversations with parents. Next slide. We talk about and this is actually my favorite part. One of my favorite parts of these types of interventions is this idea that we don't have to go into parenting work with the reactive lens. And what that means is a lot of the interventions out there are consequence-based strategies. How do we reinforce differently? How do we attend differently? How do we, do a timeout or a sticker chart or whatever. And it misses this ginormous opportunity for intervention on the antecedent side of things. If I know what sets a behavior off, that is fodder for intervention. And so we can think about different ways to create that success for the child, to set the child up for success. And one of the big things we emphasize certainly is clarity around expectations, but also incorporation of things like visual supports. How can we show a child what's expected versus just telling them what is expected? We also think about functional communication, which is this idea that, again, if behavior is communication, if I can figure out what my child is trying to tell me when they're hitting me, can I give them a better way to let me know what they need so they don't have to hit me? So this idea of actually teaching more functional ways to communicate and express needs can be a really powerful strategy for a lot of our kids. Next slide. So just as an example of how we pull is an evidence-based intervention. It's manualized, it's structured, and it's designed to kind of systematically walk parents through these different ideas. So we start by teaching them the ABCs and functions of behavior. We then work systematically through a bunch of different prevention strategy ideas. We then go through, how could we have more effective responses? And then again, we end with teaching skills. And again, I go back to that point I made earlier about how challenging behaviors are part of the equation, but adaptive skills deficits is the other part. And so having an intervention that focuses not just on reducing challenging behaviors, but also is about pushing back in and creating success around daily living skills. You'll see that Ruby also has some supplemental sessions. It's because, again, we see these kind of topical challenges with our kiddos as well. And to treat toileting issues, you're going to rely on those 11 core sessions of strategies. To treat feeding issues, you're going to rely on those strategies that come from those core sessions. So we kind of have this package, intervention package that providers can use to have structure around supporting parents and learning these strategies to then support their child. I say in essence, Ruby is about building the parent's behavioral skills toolbox so they can in turn support their child. Next slide. Ruby was originally developed to be a one-to-one kind of intervention, so one provider to one parent. What I can say is we have expanded the modality in really fun ways. We now know we can deliver it via telehealth. We can deliver it in groups. We can deliver it in groups via telehealth. We're right in the state of Washington. We're delivering it. We're training our WISE teams to deliver it. So that's kind of our wraparound services. The Lilly Cares Foundation funded an effort to train behavioral health providers in primary care. So we started with kind of the traditional model, and we in the last 10 years have been really working to expand how families can access this intervention through the various systems of care that they engage with. As I mentioned, Ruby's structured. It's got a manual that has nice like scripts that kind of lay out for the providers what they can do. And there's lots of tools that we can use in the parent workbook that help support the parents' learning. So I think the next slide is just some visuals of these components. So this is just an example of the therapist script. And then here's an activity sheet that we might like walk a parent through as we're talking about like selecting a reinforcer. And then we have little video vignettes that we use to teach, to practice skills. So I think that might be the next slide, and that will give you a chance to stop listening to my voice for a minute.
Here you go, bud. Here. Peanut butter and jelly, come on. Sit up.
Chicken nuggets.
No, I'm not having chicken nuggets.
Chicken nuggets. Chicken nuggets.
Sweetie,
Chicken nuggets.
we are not
chicken
having.
nuggets.
You had chicken
Chicken
nuggets
nuggets.
yesterday.
Chicken nuggets. Chicken nuggets.
Peanut
Chicken
butter.
nuggets.
Look at this.
Chicken nuggets.
This is your favorite kind. Mommy made it for
Chicken
you.
nuggets. Chicken nuggets.
Look at me.
Chicken
Look at me.
nuggets.
We're not having chicken nuggets again today.
Chicken nuggets.
Chicken. You can't have that every
Chicken
day.
nuggets. Chicken nuggets. Chicken nuggets.
Okay. All right, fine. All right. Go get you some chicken nuggets.
So I can't tell you how many times I've shown that video and had parents say like, were you at my house last night? But those videos are designed for us to be able to talk about like principles without having to always put the spotlight on the parent about their child's behaviors or their experiences parenting. So we can talk in the room or telehealth with a parent about like, what worked in that situation and what didn't work. We use this as an example of like inadvertent reinforcement of behavior, right? So like she like solved the problem by going and getting him chicken nuggets. The behavior episode was over, but we could then ask the parent, well, what do you think is going to happen the next time she tries to give him a sandwich, right? And so just again, the videos are kind of just additional supplemental tools to help our families learn the materials. Next slide. To tell you a little bit about who Ruby works for, and this is the case for I think a lot of the parenting interventions that I referenced, we're talking about outpatient services, and I go back to the statement I said earlier, which is this is not a replacement for ABA, and these are not interventions for your 17-year-old with severe self-injury where there's open wounds and trips to the ED because of harm to self or others. We're talking about kiddos that have, we'll call them your classic challenging behaviors. And the good news is that's actually your tier 1 kids. So that's where the most of the kids that we're going to be seeing. We're talking about, meltdowns, aggression, difficulties transitioning through the day. I like to say a classic Ruby kid is one that just struggles getting through the day with their daily routines. The morning routine is difficult. Getting to bed is difficult. Meal times are challenging. In bedtime, bath and teeth brushing are challenging. Trips to the grocery store are tricky. Those tend to be the kids that we work with in Ruby. We have researched Ruby on kids age 3 to 14. So that's why you see that age number. But I have an asterisk by that because age really is just a number in Ruby. We really focus more on topography of behavior. Can we teach the strategies and know a parent can try it with safety in mind, right? So we're not teaching, again, the parent of the highly self-injurious 17-year-old how to use differential attention, which is going to send someone to the hospital because of a behavioral escalation, right? Like that's not going to be an appropriate kid. The flip is, and actually this is a really good, can I plug research trials? I'll let you think about that and answer that. And then if the answer is yes, then I want to plug a research trial that we can enroll people from kiddos from Idaho, or actually young autistic adults from Idaho. But what we need in these interventions are caregivers that can regularly attend. The nice thing about Ruby is it can work for kids across the autism spectrum, the cognitive spectrum. So we talk about it works just as well for that non-vocal or 3-year-old as it does the grade level 12-year-old and kind of everywhere in between. But as they mentioned, what we're really mindful of is the topography and thinking about those focal issues that really need a more targeted intervention. That really good ABA is what we would recommend. Next slide. So I mentioned Ruby is an evidence-based intervention. We published our large-scale clinical trial in this intervention back in 2015. At this point, Ruby is now considered a level 2 intervention from the California Clearinghouse for Child Welfare, which is a group that does like a rigorous review of the evidence base for interventions and kind of levels it based on the evidence base. So I'm very proud of the work that our team has done in terms of the research behind this intervention. Next slide. And I mentioned that Ruby has been studied in other modalities, including telehealth and in group formats. And also it's being implemented in groups via telehealth. Okay, next slide. Just some adaptations to Ruby. Ruby was turned into an app, and that was a way to kind of use technology to support learning. We're currently, we have 2 clinical trials going on. One is implementing Ruby in schools. So we redesigned Ruby for educators to support autistic students. And our study that we just finished was focused on para-educators, who tend to be the ones that are doing the most direct support, but oftentimes have the least amount of training on how to support autistic and IDD students. And so that was essentially taking the therapist to parent model and turning it into a trainer to educator model. We're also working on adaptations for autistic adults. So that's why I kind of said that age number is kind of an asterisk. We did a case study with four caregivers of autistic adults. And that's the publication for that one, where we showed that this actually can work really well for older individuals as well with challenging behaviors. And then we're working on some data to show how Ruby has worked here at Seattle Children's. Next slide. Okay, I'm getting out of Ruby. I'm going to go back to just general parenting interventions. Okay, so one of the questions one of the many questions we get is around just like, how do we make this work in practice, right? So I started this by talking about how we're working with some of the most stressed, overwhelmed, juggling a million different balls families. So where's the space to make yet something else work for them? And so I want to kind of talk through some of the considerations we have in mind when we're doing parenting interventions to try and set families up for success. So next slide. So I already mentioned this, but just to kind of more explicitly lay the groundwork, part of what we're trying to do in these interventions is kind of help parents kind of fundamentally reframe how they understand their child's behavior. So I talked about earlier that idea that, oftentimes families come in and when they're talking about their child, they say things like, they're being manipulative, they're being lazy, they're just doing it to push my buttons. Like there's a lot of kind of like negative assigned intent behind their child's behaviors. So, one really powerful thing we can do in this work is help them think about alternative explanations to their child's behavior. Because when a behavior feels very personal, right? Like they're doing it to push my buttons, that doesn't feel like a fixable solution. That feels like you're talking about a child's kind of core, being, which doesn't feel workable to the parent, versus this idea of saying, what if it's about something else? What if there's an alternative and maybe a better explanation to why that behavior is happening, that in parentheses is way less personal, and actually something that creates to work, right? So I mentioned that example of the kiddo, when the TV gets turned on, they scream. And a parent could completely interpret that as, again, my kiddo is just annoyed that I'm not watching their show, and this is their way of being, a jerk to me or whatever. Instead of, this is a sensory issue, an identifiable sensory issue. And if we just had headphones available, or we knew in the family home that the volume on the TV, if it stays below, 25 on the dial, we're going to prevent that behavior from happening. That's, a sensory issue that we understand. We can come up with strategies, right? So, and there's this really cool shift that can happen with families that come in with this kind of like, I'd say negative bias around their child's behavior. And just kind of by working through this process of like, what are the alternative explanations? They shift from I don't feel empowered and I feel angry to and which creates a pathway to now there's something we can do about this to improve the situation. It's a really cool dynamic that you can see kind of shift with the parent as they kind of make these connections through this type of work. Next slide. The other thing that we really emphasize in this type of work is approaching care in a collaborative manner, right? So the idea behind it is, and I want to reflect on what previous experiences potentially could be of going to an intervention, being told, this is what you need to do, and this is what you got to work on. And they're more of a top-down approach to, engagement, and instead kind of flipping that model on its head to say, you as the parent are the expert in this room right now. Like, nobody knows your kid better than you. And nobody knows better than you what are priority goals for you and your family. So this idea that we create a lot of space for families to feel like they are empowered to work on things that are meaningful for them. And then our job as the provider is just to help them meet those goals, right? So if we start with, what do you want to work on? What behaviors are a priority for you? I want my kiddo to like shower more than once a month. That's that's the goal that I've heard before. And then I can go through, well, let's understand why showering is difficult. So that's kind of where we start. And then I can say, like, here's like, in the prevention strategy session, for example, we go through 8 different prevention strategies. So I can say, like, here's a bunch of ideas. What do you feel might be helpful around your goal of showering? And then the parent can say, like, I like that strategy. I want to give that one a try. So it's kind of this like process of, family being the expert in their family and their child, us being expert in some ideas, and then kind of partnering together to co-construct a treatment plan that ultimately leads to behavioral change. Next slide. Some other things that I like to highlight just around just broader family engagement is I think it's really important if we're going to think about working with the family around any of this parenting work. It's very important they know what they're signing up for. And they know they have the ability to assess and let you know if now is a good time. And I think this is particularly important for the families that we serve because of a couple of dynamics. One is our families sit on wait lists forever. Like in my, at Seattle Children's, I think I have it's at least a 12-month waitlist for Ruby, which is just appalling. Just as an aside, I acknowledge that is an appalling waitlist. For ABA, it could be even longer, right? So our families just live on wait lists. And then some random day, they get a phone call. Hey, a slot opened up for Ruby. Can you come in on Tuesday for your appointment? And our families are really trained to say yes. Because their experience is if I say no, not right now, I'm going to get put on the bottom of that wait list and I'm going to have to wait another 2 years to get into my appointment. So I'm going to say yes, whether it is the worst time of my life. Like that, we might have called a family in the middle of some other family crisis. Maybe an elderly, parent is in the middle of, needing high levels of support or loss of employment or school is, falling apart for the kiddo. But that's when they get that phone call. And so they feel like they have to say yes. And so to me, the artful engagement is about letting them know what they signed up for. So for example, Ruby, it's 11 sessions. We take about 16 weeks. It's weekly. There's an ask about practicing in between. And then asking the parent, does this even sound like it would be helpful for you, right? So like, do they even want the intervention? And then if so, does now feel like a good time to give it a go? And I know not all clinics can set this up, but it's nice when we can give families the option to say, I want to do this, I just can't do it right now. And then to say, then you let me know when you're ready to come back and you maintain your spot at the top of the wait list. At Seattle Children's in our Ruby clinic, our attrition rate is 14%. And I say that from data of over 150 families that we served in the time frame that we looked at the data. And I strongly believe it's because we don't start treatment with the family unless they know what they're doing. and they feel like they're ready. And when I say know what they're doing, I'm very used to a family showing up to their first Ruby intake and me saying, "Oh, you got scheduled for Ruby. What have what have you heard about the program, or what did the scheduling team tell you?" And the number of times I've heard, "I don't know, I just got a phone call. I told I had an appointment at the Autism Center today." They have no idea what the appointment is for, right? So it's important for us to help communicate what that is. So I kind of in a short way call this therapy speed dating. We present what we have to offer. They present what they have to offer. We figure out if it's a good match, and if it is, we're going to move forward. And if not, we're going to suggest maybe alternative paths. So next slide. So the other element is the homework. I said in Ruby, like other parenting interventions, we talk about something in session with the expectation the parent's going to go home and practice. And this, we say practice leads you to mastery. But next, if you go to the next slide, what I would highlight is what we really need is buy-in around the strategy in order for them to be interested in practicing in order to get to mastery. And I think when we lean into this idea of you get to kind of lead what you want to work on and how you want to work on it, and our job is to make it reasonable for the parent to be successful, that's what facilitates this process. So a parent who says, "I want to do timers for transitions," my job will be to say, there's probably 50 transitions in a day. Let's pick one. Let's pick one transition that we're going to practice that timer on. So I've just changed the ask from all day, every day, use a timer to just from breakfast is over and it's time to get dressed is when we're going to use that timer. So where I'm picking, working off what the parent wants to work on, but designing it in a way that works for the family. Next slide. Common treatment barriers. These are things that we hear from families that we work on navigating. One is why am I here? And I think if we do a good job of explaining what the intervention is and how the parent can be empowered in the process, we're likely to kind of work through that barrier. One of the more challenging ones is when we have caregivers that don't agree. And that's where we can use a program like Ruby to kind of say, there's actually alternative ways each of you can kind of work on behaviors all under the platform of Ruby. As long as you understand behaviors the same way, the ABC model and functions of behavior, then we can kind of figure out how each one of you makes it work for you. I kind of went through I don't have time for this. That's our job to assess upfront if that's the case. And then in the course of treatment to make intervention strategies reasonable for the family to practice. If the family is in crisis, to me, that's not a rule out, it's a check-in. Whether they, again, feel like it's a good time. And I say that because I also don't believe in gatekeeping care. I've had families that I worked with that on paper should not have been successful, but were actually really, really great implementers and users. The example I oftentimes use is I had two parents, they were no longer together. Mom was actually unhoused at the time. She was living in her car. Dad was living at his parents' house, and the child was with dad. And as I'm hearing this kind of living circumstance, I'm thinking, I asked, is this a good time? And they both said they wanted to do it. And they showed up every single appointment. Was implementation perfect? No. But were they engaged in doing to the best of their abilities? Absolutely. And that could have been a family where I was like, this is too complicated. I don't know this is going to work. And gate keeps them out of being able to access care. So to me, assessing crisis is a conversation, but also the space for the parent to ultimately make the call if they feel like it is a good time. And then for learning differences, it's probably not surprising to think that if we're supporting autistic or neurodiverse youth, that we very likely will also at some point be supporting neurodiverse caregivers or parents. And it's our job just to kind of flex the learning process to meet the family where they are. And that's when programs kind of have that flexibility around we could use the videos as the tools, or the handouts as the tools, or the conversation as a tool. We can slow down pacing. We can check in on those, what is going to help the parent learn the materials in a way that aligns with their learning differences. Last slide. So just to wrap up, I want to highlight that parent training is great. There's lots of different types of parenting interventions. The value is they tend to be low intensity, thus low cost. There's a building evidence base of these types of interventions that can ultimately address the pipeline issues and The structure around these interventions really help facilitate implementation. These are interventions that often can be delivered in a lot of different models of care, and they can be implemented by providers of varied backgrounds and degrees. So to be very clear, the majority of providers that I train are not BCBAs. They're LMHCs or psychologists, child psychiatrists, nurse practitioners, really anyone who's in a clinical care situation where they are serving autistic youth, has the ability to, learn this particular type of model of care because of the structure that tends to go along with it. I think that might be my last slide. Check and see. Yeah, last slide. I think, okay, thank you. And I guess, sorry, I wasn't good at timing because the second you were like, you can go past your 20 minutes, you just like blew all of it. Oh, really? I can. Okay.
Karen, that was a wonderful presentation. Thank you so much for offering your expertise. And I was taking copious amounts of notes and I have lots of questions, but I wanted to open up to just our participants to see if they have any questions.
So I just wanted to real quick just clarify. So when you say that, other providers, even like medical providers can learn the parent training, what are the different ones that they can learn and how do I get it?
uh, um, well, so like the biggest thing that kind of often impacts who gets trained is who is in a place to be able to make it a billable service. So I'll start there. On the mental health side of things, we bill Ruby, for example, using CPT codes, which are, very kind of commonly used and accepted codes. This is where we get to ride on the backs of those decades of work on with other parenting interventions for challenging behavior that insurance companies are very familiar with. They're very familiar with the CPT codes for them. And I don't bill the diagnostic code that I bill is not autism or IDD. It's a disruptive behavior disorder NOS type code. F919 is the diagnostic code, which again, it makes it easier to bill for. So I also have, providers that are engaging in care as part of kind of a packaged program, if you will, like the WISE teams of the state of Washington. And that's a case where it's, they have a clinician, a parent peer, a youth peer, and a care coordinator. And in that model of care, the person who ended up delivering Ruby was the person who either like connected with it the most or had the strongest relationship with the family. So sometimes it was the family peer or family partner or the care coordinator that was the one that was delivering Ruby with the family, while the clinician, for example, was working with the kid. So it's just to say that what I have seen over the years is a lot of flexibility in who has delivered it, with again, oftentimes who can get reimbursed for it being one of the bigger drivers. But Julie, I always think about your high school graduate. In the state of Maine, we are doing this huge implementation of 400 providers in the state of Maine that are getting trained in Ruby for a type of service called Section 28, which is kind of a home-based service for youth with developmental delays or other needs. And it's high school diploma or up are the providers in that service. And Julie did Ruby certification with a high school graduate who I'm not saying like every high schooler ever could do this, but like it's an example of you get the right kind of combination of kind of background and motivation with this combination of a structured program. That this was a person that delivered to fidelity. Like Julie actually watched his sessions and watched his implementation, and he was able to deliver to high fidelity. So that's not a simple answer, but I think it's a good note around like I think there's potential for who can be a deliverer of the model, and I would be happy, or Julie could connect around potential training opportunities for the program. Yeah,
I would love that. I would be so excited for that. So thank you.
Any other questions from our participants? Okay, I'm going to open up to the panel. Travis, do you have a question?
Hi, Dr. Bears. Thanks for the presentation. I'm working in specialty clinics as kind of a co-located therapist. We have integrated folks that run like a health and behavior interventionist modality or kind of that short-term piece. And Ruby kind of fits into that as well as some of these other, even PCIT informed kind of treatments, things like that. Do you have any direction of like how these kind of modified or informed evidence-based treatments can be brought into primary
Mhm.
care around that?
That's a great question. And the work that I've done here in the state of Washington, I've seen a couple of things happen. One is that, you know, I'd say maybe a third or so of the providers that are embedded in primary care have the ability to do kind of the more traditional model, which is like the 1 hour a week, for the, 11 sessions. But what I see more often is I call it the cherry picking version of Ruby. And the best way I like to conceptualize it is who's the holder of the behavioral skills toolbox, right? So the provider is certainly the holder of the behavioral skills toolbox. Like, all 11 sessions of Ruby are just individual evidence-based practices that are kind of compiled into a package, right? And so in traditional Ruby, the plan is the provider starts with the toolbox and systematically teaches the toolbox to the family. So the family walks away from care with the entire toolbox. And the idea behind that is I tell in good Ruby, if I've done that, I will never see them again because the parent now has all the skills so that when 6 months later, some new behavior inevitably pops up, they have the foundation and the skills to know what to do about it, right? In a primary care model, what I've seen sometimes is that the provider holds the toolbox and it's more about in that 30-minute consult, they're learning about the family's needs and then they're making the decision about which tool am I going to pull out and share today, right? And so I think to me, there's the pros and the cons. The pro is it allows it to be a workable model and it meets the family's needs in that moment. And that's just that's the model that's required for that kind of context. The downside is it does mean when a new behavior pops up, if the tool that was taught today doesn't work for the behavior, in 2 months, they need to come back for that next little 30-minute kind of dose of like, what about this new behavior? And so to me, it's that difference between are we working to kind of like hand over in its entirety kind of the tools, or is there a model of care that allows for that? Or is the model of care just by design, which is fine? Because again, every single session is an evidence-based practice, right? You are giving the parent an evidence-based tool, even if it's a 30-minute consult. But it's just that differential of are they getting one of the tools versus the kind of whole toolbox. So does that make sense? Or
Yeah, yeah. Do you think it could be done so like as a uh, PCPC and the kiddo, so in these some of our rural spots in Idaho where we don't have the resources and availability, our PCPs are that resource and are the available individuals. So would you uh, could you see it still being effective again across these multiple parental pieces where they could have effectively do it in a 15-minute kind of PCP, or would you suggest like no, we might want to look at still trying to extend it out into the community or find some community resource that could support more of that 30-minute or a little bit longer sessions to be able to build that skill level?
yeah, but I would always advocate for the more
The long
the
run.
more the better. Yeah,
Yeah,
they're
yeah.
crazy. But I think the I think I would never say don't give parents good evidence-based information, right? And you can do that in 15 minutes. To me, part of that kind of even shorter model is about a provider changing their framework and how they're listening to what the behavior is, how they're conceptualizing their understanding of the behavior to inform the information that they're giving, right? So it's the idea of this is the best way I like to think about it. Families are really used to showing up somewhere and like dumping a behavior onto a provider, like my kid has meltdowns. What do I do? And the expectation is the provider's going to say, oh, well, if he hits, you should do this. And if he screams, you should do that. And if, in it's this model of behavior equals strategy. And the thing that even in a 15-minute consult you can carry with you is this idea that that's not the approach I'm going to take to problem solving. The approach I'm going to say is, I hear you tell me that he's hitting. What sets it off? Like, you're asking the questions of like, what sets it off, and how are you usually responding, and why do you think, why it's going on there? And when you just flush out that conversation a little bit more using that model, that will allow you to get closer to an evidence-based practice that's more likely to be effective for that family, even just by, again, shifting how you think about learning about the behavior that you're hearing from the family. So I'm looking at Julie, my Echo Ruby expert here, and if you have any additional thoughts around that.
Oh, I agree. And yeah, the topography of the behavior never dictates the function. The same topography can have different functions with different children or even in different contexts. So yeah, I totally agree with that. There are lots of people, you can buy Ruby the manual on Amazon, and people can pick it up and take it and use it. There is a process to go through if you want to become certified in Ruby and how to do it. And so that's where I would be like thoughtful about, is there somebody who could potentially go through that process and learn Ruby to fidelity, feel really confident in it, and then they can be like an in-house trainer to help other providers take at least pieces of Ruby, depending on what the model is. If you've only got 15 minutes or 30 minutes, I've trained providers who only have 30 minutes, and then they're taking different pieces of Ruby and through multiple contacts with a family, teaching different parts of it. Is that the ideal design? No, I want them for 14 weeks where I can hold them and teach them. But it helps that particular family who's still on a wait list to try to get into services to combat those issues and give them at least some tools from the toolbox in that shortened period of time. So, there are a lot of states out there who have gone to trying to get more providers certified in these programs. And that's something that I hope the state of Idaho might look at, is getting more people trained in things like this. So that's my 2 cents.
Hey, Karen, I just have a question. So this is Elena again. We have just a few more minutes, and I have a couple of questions that I think would be helpful in terms of just take home messages. And so one is, we're always trying to access ABA therapy, helping our families try to access ABA therapy in Idaho. And of course, there's still a lot of access issues. We do have providers who do PCIT. We do have providers who do parent management training type of interventions. This Ruby intervention sounds really awesome and promising. And now I'm going to go and buy the book, and in my feedback sessions probably do, use some of it to be able to coach my families. What would you say, like, given we don't have a lot of access to ABA, and given we don't have a lot of access to these others kind of evidence-based interventions, kind of what would you recommend a provider tell a family in terms of what to look for in a provider who's going to help with their child's behavior? Recommend somebody who does PCIT, or what would you recommend?
Yeah, I mean, again, I think they're kind of like the best case scenario, and then what's kind of the close enough. Any evidence-based intervention for challenging behaviors, I think, is a great place to go. So PCI, I mean, they're doing research on PCIT for autistic youth, and other like, we do incredible years here at Seattle Children's, and I have a lot of families that have gotten incredible years instead of Ruby or before Ruby, and have found a lot of success with those programs. I think the best way I like to think about it with the little differentials is like, those programs to me tend to get families like 75 to 80% of the way there, because there's so much overlap. But what parents tell me is there's just something that's missing, and it usually is around kind of those like important considerations around kind of how their autistic child communicates, or then maybe social reinforcement isn't going to be like the most powerful, thing to motivate change. So it's fair to say that they will go a long way. And I would say if PCIT is an option, for example, like absolutely make that referral. But the other piece that I think about is beyond kind of PCI, other kind of parenting interventions, is providers that are working on kind of that conceptualization of for themselves, understanding behavior through the lens of autism and IDD, right? Like I think it's like kind of that next step of like the bread and butter strategies can do a lot of work, but like there's a lot of really cool doors that open up when you kind of add, I say, things through a behavioral lens versus a behavior analytic lens. And I say that as someone who grew up under the behavioral lens and kind of moved over into the behavior analytic lens of understanding behavior. And there's like the Venn diagram is very overlapped, but the stuff that doesn't overlap is really cool and can be really powerful stuff. So yeah.
Okay, thank you so very much. We're at about a minute now. Does anybody else want to make any comments or ask any other kind of final questions for Karen?
So I have a patient who I literally saw this morning, new patient with a 6-year-old with autism with behavioral issues. And I'm trying to make sure, what resources do you have? And I'm checking in on all of this stuff. And I'm just the medication manager. But I'm like, have you looked into this and that? And have you checked this? And mom told me, she hasn't done any parent training, but she really wants some. And I'm like, I have great news. I'm about to go to a session that's going to talk all about parent training. And next time I see you, I'm going to have all these resources for you. So she's in, Idaho. What would be the best way for me to direct her right now? I mean, I want to look into being better with the Ruby myself and being a resource for her in that way, her and other patients. But if I'm going to see her in 1 week, what would you recommend for a medication manager to direct her to get her some parent training?
Julie, is that one you can take? I'm just thinking as a Ruby person in.
I'm the only Ruby certified provider in Idaho. So it depends on if they have Medicaid yet or not, or other forms of insurance. Yeah. I will try to help you, Michaela, find sources of parent training. I've got you written down as a person to follow up with via email. So I will email you, Michaela.
And there's also some really great like online resources you can share with families. I know like the University of Washington has a really great website that has parent management training videos on it. So I think just it just depends on how much time you have to sit down and kind of go over some of these concepts with families. But I know in like my feedbacks with families, I'm always talking about antecedents and triggers and trying to understand kind of the reason behind the behavior and the function of the behavior. And I think that's actually super helpful for families to just hear that. So I'd be happy to share some websites as well, in addition to whatever Julie and the rest of the panel can provide.
I want it all. Thank you so much.
Thank you so very much. I think this pretty much wraps up our echo session. Karen, you did a very nice job filling up the entire session. It was so helpful.
Shocker, I can talk for hours.
I didn't have to do much work. So thank you so very much. And we will see you next time. I don't know, Eric, if you want to chime in.
Yeah, so next time, it looks like our topic will be navigating the Katie Beckett program to support needs of autistic children. This is Julie, you're presenting. And again, that's on August 8th. So hopefully you all will be able to join.